Sandy Dunn at Born Ontario. Welcome to our Born Provincial Rounds today. It's my pleasure to introduce Liz Darling and Geneviève Gagnon. I'll just tell you a little bit about them in a minute. Our topic for today is midwifery-led birth centers in Ontario, new options for families. And just before we start, to let you know what we will do is have the presentation first, just to expedite the information flow to you, and as well ensure we have time for questions and answers at the end of the session. You will be able to either call in following the webinar. You can press 01 on your telephone keypad to place your question in the queue, and press 02 to remove it from the queue, and Val Emerson will be helping us monitor the phone lines. Or you can type in your question in the chat box. If you look on your screen on the left-hand side, you'll see a little chat icon. You'll be able to type in your question there. So this session will be recorded, as I think you heard, and will be placed on the Born website for access for your colleagues and people you may know who haven't had the opportunity to attend today. It will be posted there in the next few days, so just to be aware of that. So without further ado then, I'd like to introduce Liz first. Liz Darling is a registered midwife who practices in Ottawa with the Midwifery Group of Ottawa. She's also an assistant professor in the Midwifery Education Program at Laurentian University. She has a master's degree in health research methodology from McMaster University and is currently a Vanier Canada Graduate Scholar at the University of Ottawa, where she's working towards a PhD in population health. Her doctoral research is an investigation of the impact of universal hyperbilirubinemia screening in Ontario. She's a member of the Birth Centre Evaluation Working Group. And co-presenting with Liz today is Geneviève Gagnon. Geneviève is a registered midwife as well, and a practice partner at the East Ottawa Midwives with privileges at the Montfort Hospital. She provides midwifery care to rural francophone women at the Centre de Santé Communautaire de l'Estrie, a community health center in the village of Bourget. And prior to midwifery, Geneviève studied nursing at the University of Ottawa. She was actively involved in the Association of Ontario Midwives Birth Centre Working Group, which successfully lobbied the provincial government to fund midwifery-led birth centers. In partnership with the Champlain Maternal Newborn Regional Program, Geneviève and a group of Ottawa-based midwives submitted a proposal to have one of the birth centers established in Ottawa. And just this year, January 2013, the Ontario Ministry of Health and Long-Term Care confirmed that Ottawa would join Toronto as a birth center pilot site. As an advocate for innovation in maternity care, Geneviève is very pleased to be the clinical lead midwife for the Ottawa Birth and Wellness Center, a community-based facility that will help women and their families realize their goal of a normal and healthy childbirth. And Geneviève and Liz are going to share the presentation today, and I'm going to pass over the mic to Liz, who's going to start us off to introduce the topic and go forward. Over to you, Liz.
Thanks, Sandy, and thank you everyone for coming today. I'm just going to advance to the next slide here. When Geneviève and I first gave this presentation, we actually did it for a conference here in Ottawa earlier this month, and we had Wendy Catherine with us as well, who works with the Ministry of Health. And so there are a few slides in our presentation that were slides that she delivered that I'll try and do as well a job at explaining for you. In terms of our objectives overall for the presentation today, we just want to give people some background about the idea of birth centers as a choice of birthplace and review a little bit about the political context that has led to us having the birth center demonstration projects approved here in Ontario. Then I'm going to talk to you a little bit more about some of the research that's relevant to looking at out-of-hospital births and birth center births. And then Genevieve's going to talk to you a bit more about some of the details around the birth center project here in Ottawa, in particular the eligibility criteria and the kind of services that are going to be offered at the birth centers as well as at the birth center in Toronto. And then we'll finish up with me talking a little bit more at the end about how what the plans are for evaluating the birth center demonstration projects. So the midwifery program in Ontario is now almost 20 years old. We're in our 20th year. Funding of midwifery began in 1994 And there's been strong support from the Ministry of Health throughout the past 20 years for midwifery. This is a quote from Deb Matthews, who's the Minister of Health and Long-Term Care, just reflecting on the evidence about the quality of care that's provided by midwives. There's certainly good evidence now that midwifery care provides ends in excellent patient outcomes and is providing good value for healthcare dollars. Women who receive midwifery care end up having lower rates of medical and surgical interventions, which obviously has benefits for moms and babies. And the Birth Center project has sort of grown out of this support for midwifery in Ontario. And I guess just to set a bit of the context around birth centers, in Quebec, the midwifery program in Quebec started with midwives working in birth centers. But as midwifery has grown across the country, we have seen the growth of birth centers. So in Manitoba now there also are birth centers. And there was a strong desire, even from the beginning of regulated midwifery here in Ontario, to include the option of birth centers for women. And often people think, when they're thinking about birth centers in Ontario, think that we haven't had birth centers. And that's actually a little bit of a misconception, because there has been a birth center in existence here in Ontario since 1996. The Six Nations of the Grand River established a birth center at that time that currently serves about 100 to 120 families a year. The birth center there was established with the Aboriginal, or through the Aboriginal community there, but it has received some funding from the Ministry of Health and Long-Term Care. And at the moment, the women who are and their families who are served in that birth center have the option of either delivering at the birth center or giving birth at home. So at the moment, the split in terms of actual location of birth at the end is about 50-50. And the birth center demonstration project that's been approved that we're talking about today is a project to look at expanding birth centers in the province, and the two initial facilities that are going to be opened will be here in Ottawa and also in Toronto. And just in terms of where the decision from the Ministry of Health to go forward with funding birth centers comes from, it really sort of fits into the current policy around healthcare. And one of the key pieces of that is the idea of the right care in the right at the right time in the right place. And so we know that for low-risk births, there's good evidence that births outside of hospitals can be a safe option when there's good support from trained care providers and appropriate screening. And so trying to establish birth centers provides another option in terms of being able to move care out into the community where appropriate. So I'm just going to move on now to talking about some of that research evidence that supports birth outside of hospital. There's three main kind of areas of research that I want to touch on today. The first are some really large studies that have been done on birth centers and looking at outcomes in birth centers. These are both large prospective cohort studies that have been done in the UK and in the US. I'm also going to talk briefly about Canadian home birth research, because we know that the care that's going to be provided in the birth centers is being provided by the same midwives who would be providing care in other settings. So in Ontario, it will be midwives who are providing care currently at home and in the hospital who will add the option of birth centers to the care that they're providing. And we currently do have some good research about what the outcomes are for out-of-hospital births that are happening in the home. And then the third area that I'm going to talk about is the evidence that we have from randomized controlled trials. And this has primarily been summarized in a Cochrane review looking at alternative birth settings. And this is the best evidence we have from randomized controlled trials. And there are some challenges with using that as our sole source of information about birth centers, just because we don't actually have a lot of specific information that just answers the question of what differences does it make if someone gives birth in a birth center versus in a hospital or in another setting. And I'll talk about that when I get to that part of the presentation. So in terms of the two large birth center studies that we have, these were both published quite recently. The first one is the birthplace study that was done in the UK, and this study was conducted by the National Perinatal Epidemiology Unit in Oxford. It's quite a rigorous study, very well designed, and a very large study. And the other study that I'll be talking about is the outcomes of birth center births in the United States. And this was, again, a very large cohort study that looked at all the births within a number of birth centers in the U.S. And just for people who are interested in potentially looking at these references later on, as Sandy mentioned, the slides from the presentation will be available, so it'll be possible to go back if you're interested and find the actual references. So the UK study involved almost 80,000 births. It was conducted over a period of just over 3 years, I guess. Just over 2 years. And this study looked at comparing the outcomes of births that happened in all the different settings that are currently available in the UK. So all women in the UK receive care from midwives. Hospitals in the UK are staffed by midwives, and if women have a normal low-risk birth, they usually would be cared for by midwives during their hospital stay and may not see an obstetrician. Obstetricians do staff hospitals and are primarily involved in births that are more complicated or involve women with risk factors when they're coming into labor. In addition to the sort of standard birthing units that would be comparable to our birthing units here in Ontario, there are alongside midwifery units, which are essentially birth centers that are in a hospital. So these would be staffed by midwives. Obstetrical care wouldn't be provided in them, but they would be within a hospital building. The next category would be freestanding midwifery units, and this is the most comparable to the model of birth centers that we're looking at here in Ontario. We're looking at freestanding birth centers that are not part of a hospital building. And then there are also home births. And essentially when they looked at what births they wanted to include here, they were aiming to capture all the home births and all the births that happened in freestanding midwifery units during this time period, and then to also have a random selection of births from across the country from obstetrical units and alongside midwifery units. And they came quite close to getting very high rates of participation in all of those. So it's a pretty comprehensive population that was included here. Despite being a very large study, when you're looking at rare outcomes like neonatal mortality, it's often difficult to have enough births to reach statistical significance when you're trying to make comparisons. So they did opt to use a composite outcome of severe neonatal morbidity and mortality as their primary outcome. And when they looked at that, there were no differences in the primary outcome when births in freestanding midwifery units were compared to obstetrical units. It's important, often sort of one of the first questions that comes to people's mind when they're looking at research comparing different settings is, well, were the women comparable in these two settings? And these are, the comparisons were made between women who were low risk. So when they were looking at comparing outcomes in the obstetrical units, they removed any women from the analysis who wouldn't have been eligible to give birth in the other locations. They also had access to a fair bit of other information about the women who were included in the study. And so for all of the comparisons that were made, they were also able to make adjustments for age and parity and for maternal sociodemographic characteristics. So this is a list of a few of the other comparisons that were included in the study. So they looked at basically mode of birth and other interventions. And when we're looking again just at that low-risk population and comparing births between the freestanding midwifery units and the obstetrical units, giving birth in a freestanding midwifery-led unit was associated with much lower rates of intervention, higher rates of spontaneous vaginal birth. And the odds ratios are there for you to look at. The other piece that's reported here also was looking at the need for higher level of care. So women who gave birth in the freestanding units were much less likely to require referral or movement up to a higher level of care. So moving on to the American study, the National Birth Center study. Again, this was quite a large study, over 15,000 women were included, and they looked at a 3-year period. They were looking at 79 different birth centers across the states, so located in 33 different states. One of the limitations of this study is that they had no comparison group. So this was just examining the outcomes of women who were planning to give birth in a birth center at the onset of labor. And the data was collected prospectively, so they were following women based on what their plan was at the onset of labor, and it was a comprehensive population that was included here. When we think about how the population might have been different from populations that would give birth in the hospital, often people assume that maybe one of the reasons why we see good outcomes in birth centers is that we're dealing with a lower risk population, or a population that has other factors that might make it more favorable for them to avoid interventions or have more positive outcomes. One of the interesting things about the women that are served in birth centers in the U.S., though, is that they really don't appear to be an advantaged population. So there was quite a high proportion. You can see here, 47% of the women giving birth were having their first baby. And I don't have the statistics on the slide here, but there was quite a large portion of them that were on Medicaid. So probably a higher portion of these women were of lower socioeconomic status than you'd see in the general population. And also along with that, quite a high portion, I think it was over 20% of the women included in this study had less than had high school level education or less. So of the women who started in the study planning to give birth at the birth center, 84% of them ended up actually giving birth there. 4% of the transfers happened before the woman was even admitted to the birth center. So although that's where she planned to give birth, risk factors presented early enough that she never made it to the birth center. And then the other 12% of women were transferred intrapartum. But only 1.9% of the mothers or babies required an urgent transfer. And again, when you look at the outcomes here, there are quite low rates of intervention. So a very low rate of cesarean section of just 6%. 93% of the births ended up with a spontaneous vaginal birth. There were no maternal deaths in this cohort, and low rates of intrapartum fetal mortality and low rates of neonatal mortality. So I'm going to move on to the home birth research now. And there are two studies that I'm going to just briefly talk about here. The first one was conducted by Patty Jansen and her colleagues in BC, and the other was conducted by Eileen Hutton and colleagues here in Ontario. And both of them are looking at home births attended by midwives in these two provinces. So the BC study was a prospective cohort study. The data there was collected in a database similar to BORN, the BC perinatal database. And it included all home births over a 5-year period, so from the beginning of 2000 until the end of 2004. And they included in this study women who would have been eligible for home birth who actually had a home birth, women who were attended by midwives in hospital, and women who were attended by physicians in hospital. When they looked at perinatal outcomes, the planned home birth group had a very low and comparable rates of perinatal deaths, so there were no statistically significant differences between them, although the point estimate was lower for the home birth group. And there were also, again, as in the other two studies that I've talked about already, lower rates of obstetrical interventions and also lower rates of other adverse outcomes. So low rates of things like induction, epidural use, lower rates of postpartum hemorrhage. And moving on to the Ontario study, this was a retrospective cohort study. Although the data was collected in the same way, it was collected as part of the Midwifery database, which was one of the founding databases that's now incorporated into BORN. And this study looked at all the home births that occurred in the province of Ontario during a 3-year period. They weren't able to have a physician comparison group, but they did compare the births that happened at home to births that were attended by the same midwives that would have been eligible for home birth, but that happened in the hospital. And again, there were very low rates of perinatal and neonatal mortality. no significant differences in their primary outcome, which was again a composite outcome that included neonatal severe morbidity and mortality. And home birth rates were also associated with lower rates of serious maternal morbidity, so again things like severe postpartum hemorrhage, and lower rates of intervention, including cesarean section. And I've just, at the bottom of this slide here, included a comparison of the rates of cesarean section. So again, quite comparable low rates of C-section, similar to what we saw in the American study on birth center births. And moving on to the randomized control trial evidence that we have, this looks at birth in alternative settings, and the challenge here is really that the alternative settings that were studied are quite diverse. So it includes some alternative settings that were within hospital, as well as alternative settings that were out of hospital. And the differences in location of birth in these studies is sometimes confounded by important differences in the way that care was provided. So it may have been different people providing care in the two settings that were compared within the same trial, or it may have there may have been differences in the amount of continuity that the women cared for in the different settings experienced with their care providers. But all of these studies were sort of looking at effects of the actual location of birth. And some of them were looking at quite unusual types of settings where they were, focused on big differences in the furnishings and the way that the birth room was set up, whereas other ones were maybe looking at more traditional type furniture within the location but a different place. So there really are some limitations in what we can conclude from these studies. But when they did do analysis looking at the differences between the studies, where there were different staff involved in providing care between the two groups or not, it didn't look like that had any major effect in terms of outcomes. But it still is difficult for us to tease out the effects about continuity of care provider from the independent effects that would be attributed to the physical birth environment. And this next slide just shows, there's two slides here which show some of the summarized outcomes. So again, the sort of the trend here is confirmation of decreased rates of intervention in alternative birth settings. So on this slide, for each of the outcomes, there were 8 different trials whose results were pooled together, and lower rates of epidural, oxytocin augmentation, instrumental vaginal delivery, and episiotomy. And the next slide just has a few more outcomes. So 6 of the trials looked at whether or not women had no intrapartum analgesia or anesthesia, and there was a higher rate of women ending up avoiding analgesia or anesthesia, higher rates of spontaneous vaginal birth, higher rates of breastfeeding at 6 to 8 weeks. Both of those differences are relatively small, but quite a big difference. Many more women likely to give very positive reviews of care in the group that gave birth in alternative settings, and there were no apparent effects in terms of adverse maternal or neonatal outcomes. So with that, I think I'm going to hand over to Geneviève here, and she's going to talk to you a little bit about some of the preliminary research that was done in preparation for putting together the proposals for the birth centers. There was a bit of research looking at what women were interested in, both in Ottawa and Toronto. So, Geneviève?
Thank you, Liz. So I'm going to talk about the Midwifery Client Birth Center study. It was a questionnaire that was filled out in May 2012 across the midwifery practice groups in both Toronto and Ottawa. These were women who were already in the care of midwives, and the questionnaire kind of focused on 3 key elements. So principally the place of birth, so with the birth center being a new option for women where they would likely choose to give birth. Also looking at where a birth center would be conveniently located for clients, and the key elements that are important for women. These figures do not show Toronto, however, they're quite comparable with Toronto's figures as well. And the principal author was Judy Rogers with her assistant, Aisha Hack. So when women were asked where they would choose to give birth in this current pregnancy, you can see that 42% of the first-time moms were considering giving birth at the hospital with a rate of 64%. 26% of women chose home birth, and 10% of women were undecided about their choice of birthplace at that time. The next slide shows women who were asked again if now with an option of birth center and choosing between birth center, hospital, and home in their current pregnancy, where they would choose to give birth. 41% of women chose birth center, 23% chose hospital, 16% chose home, and we had 16% of women who remained undecided. For their next pregnancy, when given the same options, you can see that the percentage of home birth slightly went up, the percentage of hospital birth went down. Home birth relatively stayed the same. However, there was a larger percentage of women who remained undecided about their choice of birthplace. Factors that were important. So these, across both surveys, there were things that kind of stood out from both surveys in Toronto and Ottawa that were unique to all women who were filling out the questionnaire. So it was really important for women to be giving birth with their own midwife, having tubs for use in labor and birth, wanting a comfortable space for family and friends, and differences about wanting the birth center to be either near to their home or a daycare facility, et cetera, et cetera. But those were the top ones that were comparable, again, with Toronto and Ottawa's questionnaire. This is some of the feedback that women responded to in both surveys. So again, themes really talked about good support for choice of birthplace, so having as many options as possible. There was some discussion about options for women who cannot give birth at home, whether that was because they weren't comfortable with the choice or limitations of space, or families who have multi-generational living and so make home birth not that appealing. Again, women in their comments kind of spoke to the comparable model in Quebec, and for Ottawa, there's certainly a lot of families who moved from Ottawa to Gatineau and vice versa, and so a lot of our population here in Ottawa are familiar with the idea of birth centers. That being said, people moved from all over the place, and so there were lots of comments referring to experiences in birth centers being positive and for different reasons. There's also lots of feedback about women who've had home births, would choose to have home births all over again. They love their experience, and they would choose nothing different than home birth if that was an option for them. So we did get a lot of the home birth supporters feeling that that's what they would choose over and over again. But overall, there was a terrific support for birth centers. This was an Ottawa online survey that we had conducted through groups such as the Consumer Supporting Midwifery Care here in Ottawa, but also various other Facebook kind of groups. The motivation to do this survey was past the kind of proposal phase, and it was to go and solicit a bit more engagement in the population and get a bit more feedback about if birth centers were to come, what kind of key features would women like to see in the birth centers. So as you can see from here, there are key kind of themes coming up for the birth environment. And again, this is comparable to when we design hospital units. We kind of consider all these factors to be comparable to the home-like environment. So these are topics that are seen in the hospital and again repeated in the birth centers. Pain relief options, I call this the low-tech, high-touch. For women, it was really important for them to have freedom to move and eat and drink in labor, access to water, therefore showers and baths as pain relief options. So then a lot of the touch, massage, doula support, family, friends, et cetera, et cetera. And no additional costs for non-OHIP respondents. That was very important. Continuing on the survey, we were asked whether or not what kind of services they would like to see in birth centers, and particularly in Ottawa, because the option of moving in midwifery practice was almost impossible in the time frame of setting up the birth centers. So instead, we've created the space to be able to provide allied kind of prenatal services on site and separate to the actual birthing facility. And so when asked, there was a lot of support towards breastfeeding, and we know that Ottawa is clear. We want more breastfeeding support. Prenatal care, so a lot of women did talk about, if possible, they would like to have access to midwifery care within that service. And although that's not impossible in the future, at the time that we put in the proposal, it was nearly impossible to relocate a midwifery practice group here in Ottawa. However, that will be different for Toronto, and we will speak to that in future slides. Other services talked about various kind of allied health professionals, parenting workshops, peer support groups, which we know are effective. Women want to have the support of their community. Toronto did a similar process, although I'm just seeing here the message. I will speak louder or bring the mic. Is this better? Just let me know if that's better. Toronto did a similar community consultation phase. They held a 3-day as part of the CIHR-funded project looking at Aboriginal midwifery and birth centers. There were focus groups. Perfect. Thank you. Focus groups with community members and stakeholders. And from that, they felt that there was a strong support for Aboriginal midwifery and culturally safe care. And this was ongoing, and I think before the actual call for proposals, so this was an ongoing process, and to this day is still ongoing, as I understand from Toronto. If we speak about the timeline, 2010-2012, we heard about the Ontario Association of Ontario Midwives campaign to lobby the government to support birth centers in Ontario. From that came the announcement, the Ontario government revealing the funding of 2 birth centers in Ontario. That was in March 20th, 2012. From July 4th to September 4th was the timeline to submit a proposal, with the decisions to roll out in late fall. So December 18th was the announcement for the Toronto Birth Center, and January 24th, 2013 was the Ottawa Birth Center. A little summary about each birth center here. The Ottawa Birth and Wellness Center, both are retrofits of existing buildings. In Ottawa, it's located at the corner of Walkley and Saint Laurent. It's centrally located to 4 or 5 midwifery practices in Ottawa, as well as major highways and major transfer hospitals, including the Children's Hospital of Eastern Ontario and the Ottawa Hospital, which is also a tertiary care hospital. For Toronto, again, it's a retrofit. It's a commercial space in a family social housing redevelopment. They have 2 floors within that space. The main floor being, my understanding, is the labor and delivery, or the birthing center, and the second floor being the midwifery practice group, which is 7th generation midwives of Toronto. There's access for about 80 to 90 midwives from across 7 to 11 midwifery practice groups in Toronto. It's downtown, so conveniently located to public transportation and major transfer traffic routes. And 5 hospitals are within that area, within the Toronto Central LHIN, plus the kids. These structured birth centers, so we are part of the birth centers fall underneath the Independent Healthcare Facilities Act. It is the legislation that governs all of out-of-hospital clinics and facilities, and birth centers fall into that category. The College of Midwives of Ontario is a regulator of birth centers, and they're responsible for developing the facility standards and clinical practice parameters. They're also responsible in coordinating the inspections and assessments through the IHSA program. The proposal called for specific key areas for both birth centers. So they are both not-for-profit organizations, and they do have requirements to have two-third registered midwives on the board of directors. And both Ottawa and Toronto have strong partnerships with key community stakeholders. So in Ottawa, it's the Champlain Maternal Newborn Regional Program, and with Toronto, it's the Women's College Hospital. The birth center philosophy. So registered midwives provide the same care and same services as they do in home birth. When we think of birth centers, we must think maxi home and not a mini hospital. The philosophy is maintained through the full scope of midwifery practice care as set out by the College of Midwives, which also means the midwives will maintain their hospital privileges across the province. And birth centers may offer complementary services that are funded separately from core services. We hope that birth centers in Ontario will make midwifery care and out-of-hospital births more accessible to women, that birth centers will provide care to vulnerable populations to meet the community needs, as well as providing culturally safe environments with a high volume of normal births, providing an ideal site for interprofessional education and research on normal births. And this will be through the midwifery education program and in the future potential placements with obstetric or medical students and nursing students. Services available at the birth center, same equipment and technologies as a home birth. So if we talk about the equipment, we're talking about supplies for common emergencies, instruments, including things like oxygen suction, medications to treat PPH and anaphylaxis. There are no doctors or nurses at the birth center, and this is part of the how we pay and structure physicians' billing and nurses and how they're paid and how that can work in the future with birth centers at this time that infrastructure is not there in place to collaborate fully between midwives, doctors, and nurses in the out-of-hospital setting. So hospital interventions that are not available include medical inductions and augmentations of labor anytime there's electronic fetal monitoring needed or question of forceps and vacuum cesarean section. Women will therefore be transferred to the hospital. And hospital-based pain relief such as narcotics and epidurals are also not available at the birth center. Admission for women at the birth center is when they are in active labor, so their assessments will be provided either at the woman's home or over the phone, and when there is a process of admission, it is in active labor. And the length of stay is going to be roughly about 3 to 4 hours after birth, which is the same length of stay for hospital care as well for normal, uncomplicated birth. The eligibility criteria for women choosing a birth at the birth center: they must have the care of a registered midwife with privileges at any birth center, so the Ottawa Birth and Wellness Center by both birth centers. Women must be in good health, experiencing non-complicated low-risk pregnancy with one baby head down and expected to be healthy at term. They must go into labor on their own and expected to have a normal and uncomplicated birth. Our transport protocols, these are the same again across the Toronto region and Ottawa. So the majority, and Liz talked to this about in the research, so the majority of the transports are for non-urgent reasons, so most likely prolonged arrested labor, pre-labor rupture membranes, request for pain relief, maternal exhaustion, and woman's choice if she changes her mind, will move to the hospital, and newborn instability. In this process, the midwife will call the admitting hospital, where she has privileges, and transport the woman either via ambulance or the woman's own vehicle as the situation. Most of those transfers result in normal vaginal delivery. We're talking about 4% prior to the admission, 12%, approximately 12% of those women in labor. The urgent transports, we're talking about 3.1 of provincial births in Ontario. This is from the Midwifery Outcomes Report. The most likely reasons are for abnormal fetal heart rate on auscultation, an emergency, so either cord prolapse, maternal hemorrhage, or seizure. Newborn respiratory distress or outcries of less than 7 at 5 minutes. The process for this is to call 911 and transfer to the nearest hospital with labor and delivery capacity. These will have pre-established relationships with those admitting hospitals. Volumes of births projected. So for both birth centers, we are aiming for 450 births a year, which will be prorated in the first year of operations. And that should include, or on top of that, should add the anticipated transfers as well, since we know approximately how many of those women will be transferred out either prior to the admission or during labor. And I think this finishes up my portion of the slides, and then we lead into the evaluation framework for the birth center evaluation.
Thanks, Liz. So the ministry obviously wants to evaluate this project, and in order to do that, they've contracted with Born Ontario to lead the evaluation process. So Born started off with determining what kind of expertise it needed to be able to build a working group to figure out a plan for the evaluation. And so that includes some expertise from within Born, but also looking outside of Born. There will be input from the Ministry of Health, but also from a midwifery client, from an Aboriginal midwifery stakeholder, from midwives who have experience both practicing and with research, and from a physician. And that team was put together by Born in order to come up with a framework that could then be provided to the ministry in order to suggest how the evaluation might be conducted. And there's an opportunity for the birth centers in both locations also to provide input to that once the initial draft was created. When we were looking at figuring out what kind of framework we wanted to use for the evaluation, we decided to base it on the criteria that are used to determine quality in healthcare. And a main reason for that was just to be able to align with current health policy so that we'd be evaluating things from a perspective that made sense in terms of what the goals of the ministry are in funding this project and looking at their overall goals for healthcare. So there are a few different components that are included in the evaluation. We're looking at some of the project outcomes. So this looks more at sort of what the process was throughout and how the process that was proposed by the ministry was followed. But we're also obviously very interested in looking at clinical outcomes. We're interested in looking at satisfaction, both of clients but also of providers, and part of that will also involve looking at satisfaction in terms of relationships with other providers as well. So paying some attention to transfers to hospital when those occur, and then obviously also an economic evaluation. In order to develop the initial proposal for the framework, Born did a lot of work doing a literature review to look at other evaluations that had been done. So they looked at the research that I talked about, but also looked at other studies that had been done evaluating out-of-hospital births and birth centers, and used that research to develop a really extensive list of indicators that had been used in other cases. And from that list, the evaluation working group selected indicators that made the most sense for this particular project. Some of the criteria that we used there were to be selecting indicators that would be clinically meaningful, that were in alignment with what the objectives were of the ministry in improving the birth center projects, to look at indicators that would be feasible, that we actually would be able to measure or collect data on, and that would be relevant also potentially to future evaluations for other birth centers that might be developed in the province. So what I'm going to do here is just talk about some of the indicators that have been selected and do that for you in relation to the different quality domains that we identified we wanted to look at. So the first domain was accessibility, and under this category, the proposed indicators are to be looking at the frequency of reasons why clients would not be able to register or be admitted for a birth at the birth center, and then also looking at arrivals of women in labor who weren't previously registered at the birth center. In terms of person-centeredness, part of the evaluation will involve a client survey So some of the measures there will be their overall satisfaction with their experience, looking at whether or not they had a known midwife with them at the birth, and whether or not they received one-to-one care from their midwife or a midwifery student who was involved in their care. In terms of equitability, we're interested in looking at whether or not the services at the birth center are being used equitably by women within the communities that are being served. And so the measures there would be to be looking at the distribution of the women served across the different deprivation quintiles, so that can be compared to the population at large in that area, or the deprivation quintile distribution across the groups of women who are being served by midwives in other settings. Both of the birth centers have identified priority groups that they're interested in serving. So Jen mentioned that the birth center in Toronto is focusing on providing services to the Aboriginal community there, as well as providing services to the entire community. And for Ottawa, there's a priority to make sure that services are accessible to Francophone women. So we're going to be looking at that, and then also looking at the provision of services to women who are uninsured. In terms of integration, we're looking at integration from the perspective of education, and looking at the presence of students and other healthcare professionals present at birth at the birth center. In terms of effectiveness, the indicators that were selected were the use of intermittent auscultation in labor, establishing a successful latch within 2 hours of birth for babies who are breastfeeding, and also looking at normal birth, which will be sort of a composite outcome based on definitions that will be used for midwifery standard reports in BORN. And essentially that's looking at births that avoid intervention. In terms of safety, looking at both maternal and neonatal severe morbidity or mortality, looking at the frequency of different reasons for transport, and the adherence to the eligibility criteria for the birth. The Ministry of Health is doing some work with resources that it has within the ministry to do further work on looking at what indicators will be used in terms of cost, so that element is still under development. And then this is just a list of people who are involved in developing the list of indicators that are going to be used for the evaluation. So the plan is to evaluate the first year of operation for both of the birth centers, to be looking at a full year's worth of births and looking at the outcomes for that, so that there can be a relatively quick evaluation of how the project goes. And I think that brings us to the end of our slides. So I think we're ready at this point to invite questions from people and or entertain any discussion that people want to have about our presentation.
Thanks, Liz. Thanks, Geneviève. That was a wonderful overview. I'll just remind people you can type out your question in the chat box on your screen, or press 01 on your telephone keypad to place your question in the queue, and then 02 to remove it from the queue if you don't want to be in the queue any longer, or someone else asked the question. So before we start, I don't see any questions in the chat boxes just yet, so I'll give you a minute to think about it and type them in. And perhaps I'll just check with Val, who's assisting us with the telephone line, to see if there's anyone in the queue on the telephone.
Hi, Sandy. So far I do have one question. Let me just give her permission here to speak. One moment, please. All right, so I believe it's Serena. You have a question. You can go ahead.
Sorry, that was a mistake.
Oh, okay, no problem at all.
Okay, we do.
Yeah, that was the only question so far, Sandy.
Okay, thanks, Val. We do have a question online from Lori. She says, great presentation. Thank you for all your work in securing these birth centers as a part of the Ontario landscape. How will birth centers be integrated into the rural areas of the province? I'm not sure which one of you wants to tackle that.
I can take an initial response to it, and then Jen, you can add anything if you want. At the moment, there isn't a clearly defined plan around how birth centers will grow. So I think that's part of why there's been so much emphasis on looking at developing an evaluation plan for the 2 birth centers that have been set up. I think there certainly is the potential for birth centers to play a really important role in rural parts of the province in terms of increasing accessibility to birth close to home for women, which is a priority for the ministry. But really one of the biggest factors that kind of determined the size of the current birth centers and the location of the current birth centers is the fact that in order to do an evaluation, you need to have a reasonably big volume of births. And so from a practical reason, that's really been what's dictated the fact that these first 2 birth centers are in urban centers where there is the possibility of probably meeting the objectives of having about 450 births a year. So I think if these birth centers go well, which we're expecting they should, then hopefully there'll be a lot more flexibility in terms of looking at birth centers being in a much more diverse range of settings across the province. Do you have anything to add, Jen?
Thanks, Liz.
No, Liz, I think that captures all the information.
Lori has another question for you. For the evaluation, is sustainability considered? You want to take that, Liz?
Sure. It isn't something that we have identified as a specific item where we've developed indicators on it. I think it is definitely something that will be addressed in many ways indirectly by some of the other things that are being looked at. One of the challenges with the evaluation is that we really had to limit what we're looking at, and I think there's lots of potential for there to be additional research that gets done with any of the birth centers. I think because we're looking at trying to have an evaluation done within a really quite a short time frame, some of the things like sustainability probably will be difficult to fully evaluate properly within that time frame, but they are things that we have identified as being important, and I think there is the intention to make sure that whether or not it's part of the formal ministry evaluation or not, that there is a lot of reflection that happens in these first few years at the birth center to make sure that we are able to sustain them. And I think the way that the project has been set up, despite the fact that it's happened remarkably quickly, it's been a very, very structured process. And so the structures of the birth centers really, I think, are set up to try and make them sustainable. So there will be a lot of work in the first year or few years at developing structures that will help the birth centers to run very easily and smoothly once they're in place. So a lot of collaboration with the hospitals that we'll be transferring to, a lot of work in developing protocols and making sure that there's really clear and smooth ways for things to run. I don't know whether you have anything to add along those lines, Jen?
No, can't think of anything.
Okay.
Lori has another suggestion or comment. I think you can probably see it. She's commenting it would be great to have an RN on the Scientific Advisory Committee, particularly someone with community health expertise. This would allow for broader understanding of how this service fits in the perinatal continuum. I'm not sure if there's someone on the list that you did show or on the advisory panel for the development of the birth centers fits that bill, but perhaps you can address that, one of you.
Yeah, that's a great suggestion. We do have people with nursing expertise on the working group. We don't have people with expertise in community nursing, but that's a good suggestion for us to think about. Thank you.
We have another question. I'll just take this one online, and then we'll just check with Val in a minute if there's anybody in the phone queue. So S. Renad, I hope I pronounced your name correctly. Why was it decided to have the birth centers not be adjacent or physically connected to hospitals? It seems to be that every second you can save in an obstetrical emergency is worth saving. So waiting for EMS transfers is not an ideal scenario.
I think when we look at the research that has been done on birth centers, and as I mentioned when I was talking about the research earlier in the presentation, there is a bit of a trade-off often between having a birth center that's actually co-located in a hospital versus one that's truly a freestanding birth center. And part of the advantage, I think, in lower intervention rates that happen in a birth center often comes from the fact that there is that time barrier towards accessing interventions, and it really helps to maintain judicious use of the interventions. And I completely agree that when you have an emergency, often you want to act very quickly. The reality, though, is that the vast majority of the time when you're looking at making a transfer into hospital, the amount of time difference really would be quite negligible in terms of what the actual outcome would be. It's really a very small number of cases where the difference of 5 or 10 minutes might make a significant difference. And the majority of the time when you're looking at emergency situations, often because of the risk screening that's done before women even get to the point of planning to give birth in the birth center, the chances of that happening are dramatically smaller. And so when we look at the home birth or out of hospital birth research in general, both the research that I talked about on birth centers and the home birth research, we don't see the time required to transport to hospital making a significant difference at an overall population level. So I think that's part of the reason for it. And interestingly, I didn't talk when I was reviewing the UK study about the outcomes there that happen in what they call the alongside midwifery units, which would be like birth centers in hospital. But there really is a gradient in terms of the advantages that you see of moving out of the obstetrical units. So you do get lower rates of intervention in the alongside units, but the rates of intervention are much lower in the freestanding units. So it's a bit of a trade-off, and I think really it's the risks are so small when you have good screening, good systems of transport and referral, and you have skilled attendants attending the birth, that it's quite reasonable to be offering women the option of giving birth in the freestanding birth centers.
Thanks, Liz. Val, is there anyone in our phone queue?
No, there's no questions in the queue right now.
Okay. I just have one question. We have gone through the questions that have come in through the chat box so far. But my question is about the public profile, and I'm just wondering, will women who opt for birth in the 2 freestanding birth centers within this pilot project be women who have already made the decision in their lives to search for and be cared for in their pregnancy within a midwifery practice group, and therefore once they come into the midwifery practice group, they will be told about the freestanding birth center option, or is there going to be a public marketing process put into place to sort of inform the public in a bit more detail than perhaps anyone might have heard before about the opportunities for births if you meet the criteria to qualify for it in these freestanding birth centers? I just wonder what is planned in the future about letting the general public community surrounding these centers know more about this.
Thanks, Sandy. That's a good question. Do you want to answer that one, Jen?
Sure. The Ministry of Health and Long-Term Care is going to be putting out their publication to community health centers and primary physicians' offices to inform the public generally about midwifery care. and giving birth at the birth center. But the caveat is that they must have care under a registered midwife to be able to access the birth center. So there is going to be this public information talking about you must have care and be under the care of midwives and how to access care from midwifery practice groups locally in each region. So that's going to be looking, next few, I'd say weeks to months at latest. Ministry is going to be rolling out their public information, and then there will be other information from available at the College of Midwives of Ontario and also the Association of Ontario Midwives websites that will talk informally just about birth centers and this being a third option for women who are cared for by registered midwives in the province.
That's wonderful. Thanks so much for that, Geneviève. It's 1 o'clock now. We have no more questions in the queue and no more questions online. And therefore, we're at the end of our allotted time that we have for the webinar space. So I'm afraid we're going to have to sign off today. And I just want to thank our two speakers, Liz Darling and Geneviève Gagnon, for giving their time to come and share this information with us. We truly appreciate it. We know they are both very busy right now with their call schedules and managed to fit this opportunity in, so we appreciate that very much. So thank you all for joining us. We are breaking now for the rest of the summer. Bourne Provincial Rounds will not run in July and August for those of you that are regular attendees, and we will be scheduling Bourne Provincial Rounds. The next session will run September 19th, normally the third Thursday of the month. So stay tuned in the fall for the announcement, and have a great afternoon today, and all the best for a good summer to everybody. Thanks so much, all. Bye now.
Thanks, Andy.
Thank you.